25 years of periodontology in Europe?
Well, I think it has been a fantastic celebration, and I would like to thank you, Mariano, for this fantastic program on behalf of all of us. I think we have learned so much that it's really difficult to pinpoint what are the critical elements. For sure, we go home with new clinical tips, and these are the easy ones because we have seen them, we bring them back, and we apply them. But to me, something incredible happened in this meeting because for the first time, we had a patient on stage. It's a revolution. And the challenge for us is to live up to this, putting really our patients in the center of what we do, of our treatment. And I think it's really what we have to do, reinvent ourselves and our emphasis to live up to this challenge.
So what we have thought, Mauricio and I, that in order to bring these 25 years of periodontology in Europe, we would like to bring to you the main actors of this travel. And we will bring to you some of the key concepts that we have learned, and we will try to put those concepts in perspective from the results of this Congress. So like everything we teach in the universities, we will start with etiology and pathogenesis. And I would like to ask Professor Ian Chappell from Birmingham, what's his insight to etiology and pathogenesis in the last 25 years?
The theories of microbial etiology of periodontal diseases really took off in the 1960s with the Harold Lowe experiments, the experimental gingivitis experiments, which showed that if you allow plaque to build up on teeth, that triggers inflammation gingivitis within the gingival tissues. And then if you remove that plaque after 3 weeks, in the case of the Lowe study, then the inflammation will resolve. So that was as close as we got to proving cause and effect. And at the same time, there was some very nice work being done by Roy Page and Hubert Schroeder, looking at what happens within the tissues, at the histological changes that happen during the development of that inflammation. We now recognize part of a continuum, but not all patients with gingivitis will get periodontitis. So we learned a lot about the bugs and how the biofilm is important in triggering periodontal inflammation. The 1970s really saw the emergence of the concept that actually not everybody gets periodontitis, and yet everybody has plaque in their mouths. So this raised the spectre of susceptibility. Some people seem to be susceptible and some not susceptible. And that was really reinforced with some fairly classical studies called natural history studies, and probably one of the best known was the one by Harold Lowe again, based in Sri Lanka, where they studied tea workers because tea workers have no access to oral health care. And what that demonstrated was if you looked at that population in their natural state, there were a small group of about 10% who had no disease, no tooth loss. So they seemed to be resistant to the disease. And then there was another small group, around about 10% at the other end of the spectrum, who were highly susceptible, had lost most of their teeth, had a lot of disease. And then in the middle, you had, if you like, a sort of a Gaussian normal distribution of susceptibility. In the 1980s, we saw that taken to the next level with studies by Sigmund Sukransky, Anne Haffergy, Max Goodson in Boston, where they looked at site specificity and, if you like, tooth specificity. And they showed that, that the pattern of disease is unpredictable. And if you follow it with time, then there will be periods of quiescence and then active periods where the disease is actually happening and you're getting tissue breakdown. In the 1990s, we started to identify really which groups appeared most susceptible. So in the 80s and 90s, smokers really emerged as being highly susceptible. Patients with diabetes that wasn't well controlled or was undiagnosed. And those sort of risk groups then gave us a handle on why some patients were getting disease and others weren't.
Well, I think that this is very important, the susceptibility at the center, and we have been talking about susceptibility for quite some time. I think really the time has come, in my opinion, to try and change our paradigm. We have been for so many years prepared to live with the susceptibility of our patient. Today, it's really the time in which we have to start asking ourselves, how do we reorganize our practices or refocus our practice to actually be able to manage this susceptibility? And this is one of the things I will bring back to my office.
Yes, but it is clear about susceptibility, but listening to Professor Chappell, it is not clear to me whether in these 25 years we have learned whether it is more important the infectious part or whether it is more important the inflammation part. Which is the main player in this process? So I will need to ask back again to Ian what it is important.
The environmental hypothesis. And what that hypothesis is about is, well, actually, bacteria are part of our lives. Human bodies are mostly bacteria. And if they're good bacteria and they're health-promoting bacteria, then the immune system will be in balance with those bacteria. So it's the whole environment that matters. But the biofilm changes from being health-promoting to dysbiotic. And dysbiotic means it's changing in character and it's starting to affect the immune system. And when things go wrong with the immune system, that causes tissue damage, if you like, as a side effect. The analogy I would finish off with in today's world is that the bugs are like the key that starts the car engine. So they initiate the process. But actually what drives the car is an abnormal host response. And that abnormal host response is underpinned by those risk factors, the uncontrolled diabetes, the smoking, some of these genetic factors that we can't quite get a handle on just yet. There's a wonderful quote, and I always use this, by Bob Jenko. It was in 1992 when he said, "We are at the end of the beginning of research into periodontal diseases," which is quite a poignant quote. What it says is that we know a lot, but not enough to move to the beginning of the end.
Well, I think that we have a dichotomy, and this dichotomy is important in our practice. In some of the sessions we have heard microbiologists tell us that the microbes are the drivers. In other sessions, we have heard host response people telling us that's the host response. In other sessions, the risk factors. And I think we need to try and reconcile all of this, because at the end of the game, in our practice, things have to come together. Don't you think, Mariano?
I think so, because we need to translate into therapy, into practical terms, whether our main goal of therapy is anti-infective or our main goal of therapy is anti-inflammatory, or perhaps both. But we need to apply all this knowledge. So let's start with one of key applications, which is clearly the one that most of us do, and we have been doing in the last 25 years, which is the anti-infective approach. And we are going to ask to Professor David Herrera from Madrid.
Even though we know that periodontal diseases, specifically periodontitis, are specific infections, we are not able to use this information for specific treatments. And prevention and therapeutic strategies are not specific today. For the treatment of periodontitis, we mainly use mechanical approaches based on subgingival debridement and pocket elimination. These are not specific approaches. Sometimes we may be able to use specific strategies based on local or systemic antimicrobials, but these treatments are not free of controversy. For the future, we need to develop specific strategies based on the microbiological profiles of our patients. The same is true for prevention strategies. We have mechanical biofilm control, which may be very effective, but it is not free from limitations, especially those patients not using interdental cleaning. For those patients, we may be able to use antimicrobials, antiseptics, chemical biofilm control. These agents have proved to be very effective, but there are some adverse effects for the patients. And the development of new products based on different principles are desirable. Most of the products that we use today are antimicrobials, but maybe we will be able to develop products that avoid the addition of the bacteria in the oral cavity, that interfere with the interbacterial matrix of the biofilm, or even those that are able to destroy the biofilm by itself.
Well, as a clinician, I have a problem. I listen to the sessions on microbiology and on antibiotic therapy, and I have to reconcile a problem that is, on one side, I hear that from a public health standpoint, I need to be careful, not overuse antibiotics. On the other side, it seems pretty clear that if I add an antibiotic, I will get better results. So a dichotomy. I would like to know, Mariano, what do you do in your graduate program? What do you teach?
Well, basically, we also have this dilemma of efficacy on one side versus hazards on the other side. And what we try to teach our students is the treatment with systemic antibiotics is not the standard of therapy for the treatment of chronic periodontitis. We need to provide periodontal therapy, evaluate the patient's response, and only in the most aggressive forms of periodontitis and the non-responders or the very severe are the ones that we consider the use of antibiotics. And of course, in an academic environment, we look in these particular populations for the predominant pathogens in order to drive our antibiotic therapy. But clearly, this is a very academic approach. And Mauricio, you are in private practice also. How do you approach the treatment of your patients when antibiotics is part of the decision?
Well, I have to first of all say that we all need to realize what is our population. I'm a specialist. I tend to see people with more severe, more aggressive forms of a disease. So what I end up doing in my practice is I use an empiric approach. I do not have the access to all you are saying, and perhaps I will not even know how to really make sense if I add the results of such microbiological tests. And so I use empiric antibiotics, probably in between 20 and 30% of the patients. So not every one of my patients get an antibiotic.
Well, we also have heard in the address by Dr. Herrera that similarly, in prevention of gingivitis or in the treatment of gingivitis, we have been using the same antiseptics, the same molecules for many, many years. And even though it is desirable that we will get new chemicals, probably new mechanisms of action, industry has not been able to provide us with this in order to be efficacious in the treatment of gingivitis. And perhaps we could ask ourselves, perhaps we are targeting the wrong end of the biofilm. Perhaps we should target more the health-associated bacteria than the disease-associated bacteria. And this hypothesis, we are going to ask to a key person in the development of this idea. So we will ask Professor Wim Teugels from Leuven, what is his approach?
Actually, there are no good bacteria and there are actually no bad bacteria. Even good bacteria can be pathogenic under certain conditions. Basically, what we mean is that we want to exploit our knowledge around these commensal bacteria, these good bacteria with antimicrobial, anti-inflammatory properties, and try to develop new therapies, new preventive therapies, based on their presence, based on their stimulation. Probiotics have been defined as living microorganisms which have a health benefit when they are administered in adequate amounts. And basically, to make it very simple, it means that as a scientist or as a clinician, you try to add good bacteria, beneficial bacteria, to the oral cavity of a patient with the hope that they would improve oral health, they give some kind of a prevention. And these days we have already some studies that are really showing that this might be possible. With prebiotic therapy, basically we are aiming to give already colonized good bacteria in the oral cavity of a patient, give them the right substrates to overgrow the pathogens and to modulate the immune system. What I hope that periodontists will do in the future is think out of the box. And I know that many of the periodontal scientists are already good at that, but we have to go many steps further. We have a beautiful area in which we work. We have the biofilm, we have hard tissues, and to be honest, many of the gastrointestinal researchers are actually envying us because we can easily manipulate biofilms, we can get there, we can easily go into the immune system, take samples, etc., etc. So what I hope that the periodontist for the future will be is that he will be an architect of the microbiology, an architect of the immunology of your patient, and basically modulate both factors which are actually equally as important, and create an environment for the patient, for the mouth of these patients, that will be conducive for oral health for the rest of its life.
So we see here that there are 750 million people around the world affected by severe form of periodontitis. The number affected by moderate or less severe forms is in the billions. We see here that the prevalence of the disease seems to follow a gradient that is along socioeconomic development. There are 110 different nationalities, countries represented here. It's a global problem. The global burden of disease is massive. Mariano, you just finished the European workshop on prevention. What have we learned? How are we going to be able to do something about this?
Well, some of the things we have learned is that we need to develop population-based strategies based on diagnosing the risk factors of the affected populations. We have understood in this workshop what is the relative efficacy of the tools that we have in terms of prevention, mechanical plaque control, chemical plaque control, but we need to target not only the behavior of our patients, but also secondary prevention, professional intervention to targeted high-risk groups if we want to diminish the burden of this disease throughout the world. Because the problem of this very important burden is that it's not only what affects to the oral cavity, but also, as we understand today, is how these may affect the general health of the patient. So I will ask you, Mauricio, what do you think are the implications for the general health of this huge affected population?
Well, we know that there are associations and that for sure periodontitis has an effect beyond the mouth. The organism senses it, and even a small effect, we do not know how small it may be, but with such numbers, we are talking billions of people, the impact on public health is probably going to be huge. So I think it's really important to draw the attention of public health officials around the world to this possible link and perhaps think how we can manage this better.
And we have had great sessions in this Congress, mainly focused on cardiovascular disease and diabetes. What do you think, Mauricio, is the knowledge that we have today on the implications of this burden of periodontitis in these very two important diseases?
Okay, so I think it's very, very clear that at least when it comes to systemic inflammation and the early risk factors associated with the process of atherogenesis, what happens in the mouth of our patient may actually contribute to the development of atherosclerosis. It also seems to have an impact on the development of insulin resistance, on the people becoming diabetic. The interplay is very, very complicated because there are common risk factors, so we go back to this issue of the susceptibility, and the important element is really to think again about our strategies.
And also beyond these two diseases, we have emerging knowledge on clear associations, such as the role of periodontal pathogens in the development of rheumatoid arthritis, or other diseases linked with systemic inflammation like Alzheimer's disease, cancer, and even death. We have had beautiful presentation in these congresses, in this Congress alluding to this. Let me ask one of the key persons in this area, periodontal medicine, what is his opinion on these associations. Professor Phibos Madianos from Athens, Greece.
The concept of periodontal medicine has grown, and of course it will continue to grow, the more evidence we collect on these associations. We have evolved into that field, gathering a lot of information, and basically what it has done to our profession is that it's bringing the dentistry back into the center of medicine. I think that the amount of evidence that has accumulated over these decades is surely large enough that I think we are obliged to share this information with both our medical colleagues and the public at large. I personally think that if we had an infection in another organ in our body that had a sufficient magnitude and it went on latent, probably for decades even, as this is the case many times with patients that suffer from periodontal disease, then we wouldn't have a big difficulty realizing that that may have an effect on general health. Once you explain that to a patient, I think they are very eager to understand it and to learn more about it.
But it's actually more than learning more about it, I think. It's actually asking ourselves if there is a role for our team, the oral health team, to be played in the 360-degree prevention of the major chronic diseases. As we implicate tobacco cessation counseling, we implicate promotion of healthy lifestyles as part of our periodontal preventive strategies and also part of our periodontal therapeutic strategies. At the same time, we start contributing to helping the populations of our countries being healthier. And we must remember that we as dentists are the single health professional that sees the patient at the time of his life or her life when prevention is still possible. So I think this is a tremendous opportunity that still remaining within the scope of our profession, we can help society and medicine.
Yes, but of course, but at the end of the day, we dentists need to treat also our periodontitis patients, and you saw the huge burden of disease. And clearly, if we are reviewing 25 years of periodontology, we need to ask ourselves, what has changed in the treatment of periodontitis in these 25 years? And I would like to ask a master clinician working in his private practice, how do you do? So I'm going to ask Massimo De Santis how he does it.
In a practical sense, I don't think that there have been many changes as far as the approach we do have, generally speaking, to the patient. Patient, first of all, has to be instructed and has to learn and to understand what kind of disease he has and what kind of benefit you can give it to him. And this is, generally speaking, given by me with a speech when I do the first visit to the patient. Secondly, patient has to change their attitude toward maintenance of their own teeth, that is cleaning, if they have a periodontal disease. And this is one of the first steps that they do with the hygienist, that is to realize how to clean the teeth and how to maintain the teeth clean. And then they go to pass to the phase of controlling the inflammation, that is controlling the infection. Sometimes we do this with a non-surgical treatment, like scaling and replaning. Some other time we have to do it surgically. It depends by morphology, depth, kind, quality of the disease. But the approach is entirely toward the control of the infection to maintenance of a sound dentition. With the difference between today and 30 years ago, that 30 years ago our approach was to get rid of the disease together with the pockets, and by this we were transforming a patient, a normal human being, in a semi-monster with very long teeth. Now we try to control the disease and to control the infection without necessarily eradicating the pocket. We may not. We have other way of treating. We have developed a lot of treatment to regenerate tissue, and if we can afford this way, we will do it with centering our attention not only to the infectious disease, but also to the aesthetic result, so that the patient will maintain his social capability. In other words, will be healthy and will continue to smile, because to be healthy without having the capability of smiling is quite sad, for sure. We had in the last 25 years a lot of improvement as far as technicality, I would say, and as far as surgical technique are concerned, for sure, and mostly in the field of regeneration and in the field of mucogingival surgery. If I would give you some name, for instance, the technique of the papilla preservation was changing completely the outcome of the regenerative therapy from being very low to becoming very high, predictable. In the field of mucogingiva, probably the modification of the tunnel technique is very effective in the third class recession, or the multiple coronal advance flap that is enabling you to treat more recession at once with a very high chance of getting resolved the problem. But those are only three examples. What I'm going to say is that in the field of the regeneration, in the field of mucogingival surgery, and generally speaking, in the field of reconstructing the periodontal disease, we have much better technique, much more reliable technique, much more scientific information on those techniques that gives the dentist the possibility of using them effectively on their own patient.
So I think, Mariano, we are not only doing the same things in a more confident way because we have more data, but I think we have added ingredients to our cooking recipe. And in fact, the biggest challenge that we have today as clinicians is really how we are going to put together the treatment of an individual patient. And here we go back to the patient at the center, not only in terms of his wishes, but also his values, his culture. Of course, without compromising health, I hope, in the sense that health of the periodontium must remain an objective. The idea is that perhaps what we would like to do more and more is to conjugate health with perhaps limiting the adverse events or choosing the adverse events that the individual patient is more likely to accept.
And also it seems to me that there has been a change in the focus from a focus towards infection control, towards keeping the patient completely clean, to more reconstructive surgery, to more building up those tissues that have been destroyed as a consequence of the disease. And clearly, one of the things we need to understand, and we always ask ourselves, is how predictive these techniques are. How me as a clinician am able to introduce regeneration into my daily practice. How should I do it? So I'm going to ask to, of course, one of the key researchers and clinicians from Europe to answer this question. Sandro Cortellini, how do you implement regeneration in your practice?
there is today more and more consciousness that saving teeth is relevant to patients. They're not interested in placing implants. They are interested in saving teeth. So I believe everybody should revisit a little bit the way of planning a treatment to severely compromised patients, starting from this idea and understanding that there are several ways of doing good therapy, saving teeth. We are not discussing of extracting teeth that still can be kept in the mouth. When we extract what we call an hopeless tooth, we are left with a tremendous amount of bone destruction. To place an implant there is not easy. To place an implant there, it requires bone regeneration, soft tissue management, augmentation, whatever, grafts, or what is needed to do a nice job, then to place an implant. And this is not easier than applying periodontal regeneration to save a tooth. So I would say to colleagues, have at least a try. Then, of course, implant therapy is a fantastic tool in our hands to replace missing teeth, to increase and improve function, sometimes aesthetics, but is not a nice replacement of an existing and maintainable tooth.
So the key seems to be that we are, in a way, moving the line of a prognosis of the teeth that we can still try to maintain and the ones that are lost. This, to me, is one of the biggest challenges we are facing. And it is incredible, really, in these 25 years, we are now doing things that we could not dream of only 10, 15, or 20 years ago. And this is something that perhaps we need to recognize and implicate in practice. And also, you know, if on one side we look at perhaps extreme cases that are there to make us reflect of where we put the line every day in our practice, we must realize that there is a very, very high degree of predictability with these procedures. And it's really this that is what we need to incorporate in our practice.
But agree, when I read the literature, when I come to the congresses, when I visit these Europerio, when we are in the workshops, we review the predictability and it's very high. We review the efficacy as in extremely good. But still, these treatments are not generalized to most of the dentists. And it has been a challenge to drive these therapeutic processes into everybody's hands. And I would like to ask again to Dr. Cortellini, Sandro, how can we make these treatments more generalized?
There are a few reasons why periodontal regeneration did not filter through to the general practitioners. Some failures and some side effects that happen, especially at the beginning of application of periodontal regeneration, raised some concerns and some doubts about efficacy and especially generalizability of this procedure. Second, I believe the real need for expertise, personal expertise, so training, a lot of training, and the need for a consistent team approach. Lastly, and very important, the tremendous competition that came out of the development of implant therapy. So in many instances, the decision was pull a tooth and substitute with an implant instead of developing in practices a way to save teeth. We have really to trust the patient, and the patient has to trust us. We talk about behaviors, we talk about tobacco smoking, we do counseling about tobacco smoking. Also, we care of nutrition, of fitness, obesity, body mass indexes. If a patient is not following, we don't kick the patient out of the practice, but we apply what the patient allows us to apply in his or her mouth. I think the future is very clear. We are trying to expand the potential for regeneration, the potential for reconstruction, and these lines of research through growth factors, gene therapy, etc., cell therapy, whatever, has, in my opinion, a very relevant role. This will render faster, more powerful, and more applicable to more cases this kind of attitude that is saving an anatomical part of the patient, that is a tooth.
So it looks like the recipe, what we are trying to bake when we are doing this advanced procedure are actually complicated and are made up of different ingredients. Sometimes we may be tempted to ask ourselves, what is the most important ingredient? Perhaps the technique, perhaps the patient selection, or the ability to modify and prepare the patient adequately. And in a way, it is a little bit of a moot point. It's like asking ourselves if in a nice pasta dish, of course I'm Italian, I must talk about pasta, is more important to have the pasta or the sauce. You need to have everything together, and it is a challenge. It is a challenge that can be obtained, but we need to organize our practice in order to go into this direction. But I want to ask you a question, Mariano, because I was a little bit, how can I say, taken by one of my comments of my brother, Sandro. And I want to know, Mariano, but in such cases, an implant is a real alternative.
Of course, an implant is an alternative, but I mean, when decided on dental implants, apart from all the ingredients that you have alluded, there is always an ingredient which is, of course, the economic driver. And of course, another ingredient is the perceived notion that implants are easier. And I say perceived because, as you have seen, when we have these severely affected dentitions, the defects that are resulted from extracting those teeth are going to lead to situations where perhaps implant therapy is even more difficult than saving a tooth. But it is clear that dental implants are a fantastic therapeutic tool for the treatment of edentulousness, for the treatment of missing teeth. And in these 25 years, we cannot conceive European periodontology without the advent of dental implants and without what the world of periodontology have done for the research and development in this area. And I would like to go to the roots, to where this started, to Göteborg, and I will ask the chairman of periodontology in Göteborg, Professor Tor Berglund, about this topic.
Everybody knew Professor Brånemark. And realizing now, when you look back of the whole enormous input that the work of PI was to dentistry, we have to realize that dentistry had a time before the implants, and then a new area began when implants were introduced. But I think that for clinicians in general, when you look at the work of P.I. Brånemark, we should keep in mind that treatment planning concepts still prevail. And what I mean is that we try to understand diagnosis, each opportunity for treatment of any condition that we recognize in any patient. But the choices for strategies, they have increased enormously since we received the opportunity to use dental implants. So we appreciate the work of PI very much. Periodontology has contributed quite substantially to implant dentistry. I think the tradition in periodontology of trying to understand the whole picture comes in here when you do research. There is a long-standing tradition of a translational approach. I mean, implant dentistry is a good example of translational research because the discovery of osseointegration has no meaning unless you can implement into a real clinical function. This has been elegantly demonstrated that what was achieved when placing an implant into the bone could be used as a very reliable and predictable means by supporting crowns and bridges. Periodontology took this even a step further because we wanted to understand in detail what really took place when you place implants, and not only in the bone area but also in the soft tissue portion, and how this tissue can be maintained over time and preserving this integrity between bone, soft tissue and the biomaterial of the implant.
So in a way, we are realizing more and more that dental implants are tools, and are tools that are very important because they expand our treatment planning options, but they should not be the driver of what we are doing, of the way we plan our cases, of our treatment decisions. I think it is very, very important also to realize that our treatment planning, the incorporation of dental implants into our practice, cannot be based anymore on data on implant survival. This was what we were doing at the beginning. So we need perhaps to go to a next stage, and I wonder, Mariano, how you are now seeing the incorporation of these tools.
Well, the issue is that for many years we were sort of bombarded with these huge percentages of success and survival rates, thinking that this was heavens in terms of treatment planning and in terms of overall prognosis. And we have heard from Tord that probably the focus was completely wrong, because at the beginning we were not focusing on peri-implant tissues. And this change into the focus from survival rates to evaluation of peri-implant soft tissue health and disease and the maintenance of crestal bone levels really has changed completely the perspective we have today towards implant therapy, because we have seen the emergence of peri-implant pathology. And again, I would like to ask Tord Berglund, what is the importance of this soft tissue portion and the importance of prevailing the health of this soft tissue portion?
The wound you create when you place an implant in the soft tissue area must heal under conditions similar to those we see for the bone healing. The time required for the soft tissue barrier to form is between 4 and 6 weeks, not shorter. And in some patients it may take even longer. So there is a very fibrous and cell-rich and vascular poor tissue you see in this connective tissue portion next to an implant. And the maintenance of this contact between connective tissue and the implant is the prerequisite by which you maintain health. If you allow plaque formation to occur on a crown, on a tooth, you will get gingivitis. Similarly, if you allow plaque to form on a crown seated on an implant, you will get a similar reaction in the peri-implant mucosa, which we recognize as mucositis or peri-implant mucositis. This will have a development over a number of weeks, 3 to 4 weeks, similar to that we find around teeth. Following this period, you will have an established chronic mucositis lesion, the extension of which, the composition of which is almost identical to the one we see in gingivitis. And this is the interesting part. In gingivitis, you can have a stable conditions for years, for decades, and perhaps for life in some patients. This may be valid also for the mucositis lesions, for some patients, and for varying periods of time. But the lesion in mucositis is always confined to the extension of the epithelium. This means that the lesion only spreads in line with the apical dimension of this epithelium. If, however, there is a disturbance of the balance between the host response in the lesion and the biofilm residing in the pocket, the lesion will expand. And when expanding the lesion beyond the limit of the epithelium, it will include the soft tissue integration, the connective tissue integration zone, and that will destroy this fabulous, important connective tissue seal. And perhaps this is the key by which we may understand how peri-implantitis may have its onset.
So in a way, Mariano, it sounds like peri-implantitis may indeed be a more aggressive type of disease than periodontitis. And, you know, me as a clinician, I have a problem. I have a problem because on one side, my periodontitis patients who have lost some of their teeth or portions of their dentition due to advanced periodontitis will benefit tremendously from these implants. On the other side, I know from the data that it looks like they are going to be a high-risk group from having some of these problems around the implants. So on one side, we of course do everything we can to treat the periodontitis to the best possible level before placing implants, but I still think we have to reconcile things a little further.
Yes, and one of, among many things that we have learned in this Congress, it was presented yesterday data from a big population study on the prevalence of peri-implant diseases in Sweden. And it was a very impressive figure with the way they have evaluated this population. About 45% of patients had some degree of peri-implantitis. And from this population, about 15% roughly had overt peri-implantitis, severe peri-implantitis, which means that probably the key is early diagnosis, is recognition, is being able to implement interventions before we get into the more severe forms of peri-implantitis. And we understand that these emergent disease or diseases are not easy to handle, not easy to grasp. So I will ask, again, one of the top European leaders in this field, Professor Stefan Rembert, to tell us how to diagnose and to treat these peri-implant diseases.
The disease as such has clinical signs of bleeding on probing. It can pass out of the pocket. On the radiograph you can see the bone loss. So in a way they are not difficult to identify. However, I would like the clinicians to identify the early signs before we have massive loss of bone around the implant, because then it is much easier to do a correct therapy, and we know that this type of therapy can work. If the patient has peri-implantitis with bone loss around the implant, we always, at our clinic, we always recommend to start with a non-surgical approach. It has a lot of advantages, especially if it's a patient you don't know. It gives you some feeling how will this patient in the future cooperate with the therapy you are providing. But in some cases you need to do a surgical intervention. The surgical intervention gives you the advantage to get a proper accessibility to the area where you have the disease. It makes it easier to clean, even if it still is difficult. It gives you an opportunity to use bone augmentation material, which can improve the healing results. You can get fantastic treatment results, and it has been shown in the literature in humans that the treatment result obtained can be maintained for at least 5 years. from the professional side, it's so important for us to tell the patient when they get the implants that it has to be managed. If anything, you need to take more care of an implant than a tooth because it's more difficult to handle than a tooth, even for the patient. So the prevention, I think prevention is really the key. Prevention and maintenance is the key to be successful in implant therapy.
So I think that Professor Renvert really wanted to give us a positive statement and wanted to leave us some positive thoughts. But I really must ask myself how far this positiveness is really implicated in practice. In practice, we are very much still confused. What shall we do? What are the approaches that are really proven? And now, in this conference, we have listened to many clinical trials that have been presented here for the first time, and many other clinical trials are underway. These are the ones that are going to really guide us. So if on one side we must be really positive, on the other side we must really recognize that the recognition of this disease, the diagnosis, the treatment, even though we have been talking about it for many years, it is still in its infancy. So I want to be provocative, Mariano, and you will please excuse me for doing this, but I'm going to ask you a question, and it is, now, discussing all this periodontitis, peri-implantitis, do you still consider that an implant should be the first choice in replacing a missing tooth, or are you thinking differently?
Well, in principle, I would say yes, Mauricio. In principle, I would say yes, implants still a fantastic tool to replace a missing tooth, although, as we have alluded, the implications of risk factors is critical in the decision. And also we need to realize that we have come a long way in periodontology with improving methods, mostly surgical methods and reconstructive methods, to improve the results of traditional restorative therapy. The pink component of the restoration has gathered more and more importance, not only around implant, of course, but also around traditional restorative therapy. And the indications are growing, and this part of practice is emerging. And I would like to ask one of the master clinicians in Europe, Dr. Otto Zur, how he does it.
It's, as it used to be, crown lengthening, soft tissue recession treatment to align gingival margins. It's pontic site development with soft tissue rich augmentation. But besides these traditional indications, a completely new field has opened up for the future due to the fact that we have realized that many of the surgical principles that we have learned and that have proven success in plastic periodontal surgery can be easily transferred in more recent challenges in reconstructive dentistry, like socket preservation with and without immediate implants, implant site development with soft tissue volume buildups, peri-implant soft tissue recession treatment, thickening procedures to mask dark-colored implant components, techniques to increase the width of the keratinized peri-implant mucosa in aesthetically demanding sites, and so on. The indication range has become huge.
But I think it's also important that as we get excited about these new areas, we do not forget the more, if you wish, mundane areas. You know, modern perio is more than ever central to restorative dentistry, also to help saving teeth. I'm thinking about the simple elements as crown lengthening, etc. And also, of course, this fantastic interplay between the restoration of the cervical area of the tooth, the root coverage procedures that have really dramatically changed the way we practice. But
also, I think it is critical that we individualize our treatment plans, because we may implement these sophisticated surgical interventions in people that really demand aesthetics or really need aesthetics, and perhaps not so much to some other people that perhaps do not show so much what we are doing. I will ask again to Otto, what are the implications of aesthetics?
Not every patient is in equal measure sensitive regarding aesthetics. The individual perception can be very different. One is already complaining about minor deviations from a pretended, let's say, ideal gingival margin. The other one doesn't care or doesn't even notice major deviations. But if patients care, it is as simple as it is. If they show their gums during smile, the pink component is essential for successful aesthetic treatment outcomes, most likely the most essential one in many situations.
Well, we have seen that aesthetics is important, surgical interventions are important, but all these periodontology around restorative dentistry needs a team approach. There are many different ways to practice periodontology in Europe, from solo practice to specialized practices, to team practices, etc. How do you do it in your practice, Mauricio?
Well, Mariano, perhaps I'm not the luckiest one in the sense that my practice is actually a mixed practice, in the sense that I have a team in the practice, but I also work with a team outside the practice. I think the key is for us to have a team. This interplay between perio and restorative dentistry only works if you have a stable partnership with a wider team. And it's not only the restorative dentist, the prosthodontist, it's the endodontist, it's the orthodontist. It's really a fantastic explosion where I still think that perio is at the center and at the foundation.
Yes, and I think this is also what Otto Zur is telling us in this small video clip.
I was always working in a team, and I'm pretty convinced that I will be always working in a team. This is not always easy, as in any human relationship, but at the end there is for me so much motivation, inspiration, such a sense of well-being that I can take out of it. Actually, I see two main demands for the future. First of all, we really do need to have more basic research to understand better the biological principles of soft tissue regeneration and to shed light on the presently more or less unknown complexity of oral mucosal healing and its regulations. On top of that, we really do need creative thinkers. Thinkers that are courageous enough to think out of the box and that are finally also able to translate their discoveries into clinical applications. But under these circumstances, I'm really very, very positive that we will be able to advance in new dimensions of soft tissue reconstruction in the near future. At the moment, I have the feeling that instead of broaden our horizon in soft tissue regeneration, there's too much scientific focus on improving techniques and developing biomaterials and indications where already today we can offer quite good solutions to our patients with conventional techniques and approved augmentation materials.
Well, what a great journey we have done to periodontology and the evolution of our practices in both periodontics and implant dentistry. We have seen some of the actors, but we have not forgotten at all who have been the architects of this build-up. And it's clear to all of us, at least to both of us who have worked on this script, that there are two architects in the last 25 years of European periodontology, and we do not want to bring them in a video clip. We want to bring them on stage, and even if it is going to be very short, we are going to ask them their opinion directly. Please, Professor Klaus Lang and Professor Linde, come up to stage.
Which? Thank you. Please sit down.
Yeah. Welcome, Professor Linde. Welcome, Professor Lang. And if you may allow me, I would say welcome, Jan. Welcome, Klaus. And as we mentioned, we would like to ask you very short questions, but I think relevant questions. And we would ask you, please, Klaus, short answers. So, Jan, let me start with you. Along these 25 years of therapy of periodontology, what would you think today should be our end point of therapy? I mean, as you have heard, we were starting from pocket eradication, elimination of bleeding and probing, aesthetics, tissue buildup, reconstruction, periodontal regeneration, all this evolution. How are we today? What we should do today?
I don't think there is a very simple answer, yes or no, to this. But if you treat periodontitis, the end point is no bleeding or probing. And a probing depth that varies within very narrow limits. I don't believe that there are very deep pockets that don't bleed on probing. So the end point of my treatment for periodontitis is a patient with very few sites that bleed on probing and reasonably shallow pocket sites.
Klaus?
I second that, and I will be more specific even. I would like to see no pockets that exceed 5 millimeters. Up to 5 millimeters, we can debate on whether these pockets can be maintained. And the second, of course, is absence of inflammation, which is absence of bleeding on probing. That will guarantee stable conditions.
So I think this is very interesting, and in a way we're now narrowing on one side on the 5 millimeter pocket that perhaps you are saying we could keep. Jan, would you agree, or is it borderline for you, or what do you see?
You know, first of all, I mean, in itself it's impossible to answer because you have patients who belong to different phenotypes or biotypes and teeth that belong to different phenotypes. It's a question of how thin is the mucosa, how thick it is, what is the resistance the tissue is able to offer to probing. But I would agree with Klaus that 5 millimeters is not such.
So then the question, Klaus, is how do we get there today?
Well, that's not an easy question to answer either. But Mother Nature has provided us with a fantastic mechanism of healing. And if we get at the etiological agents that triggered the whole catastrophe, in other words, efficacious plaque control, and then we also get the resolution of the tissues. And sometimes there are patients who have a phenomenal capacity of healing, and some others don't. But most of them, I would say, to get to the point of free from inflammation, it's in the cooperation with the patient that we go down to very low plaque levels.
But also, I don't think we should be prima donnas here on stage. Of course, pocket elimination is still a very, very valid procedure.
And do you see any value, Jan, in the individualization of treatment? You basically said there are different types of patients, different type of situations, anatomical, systemic, etc. or whenever possible, you would strive for, within quote, pocket elimination, resolution of bleeding on probing, in a way at all costs?
You know, it all depends on how effective you are at non-surgical therapy. And believe it, Mauricio, the range of...
It's very big.
It's very big. Some people are extremely good at non-surgical mechanical therapy. And we have some of our dental hygienists in Gothenburg who are phenomenal in not only eliminating bleeding or probing, but also reducing the deepest pocket to within Dr. Lang's limit.
Let me change topics a little bit, and I would like to ask you, we have heard on the figures of peri-implantitis and the problems associated. Do you believe that peri-implantitis is inevitable? Can we prevent it, or do we need to live with it?
We can prevent it to a great extent, and that is controlling the risks. But we may not be able to completely prevent it. But we certainly can come down from the figures of 30% after 10 years to maybe 1/3% per year.
Jan?
Well, this is pure speculation, and I wouldn't like to add gas to this. But I think right now, the type of implants we are using will be completely obsolete 10 years from now. So when we meet after 10 years, Mariano, I will tell you how I look upon the possibility of reducing the rate of peri-implantitis.
Well, this is very interesting, and perhaps I may start from here asking you a series of questions, Jan. Do you prefer keeping a tooth or placing an implant?
Keeping a tooth.
Keeping a compromised tooth or placing an implant?
Keeping, what the heck do you mean by compromise?
You may treat it. You may treat it.
Yeah. Then I will keep the compromised tooth.
And treat it.
And treat it.
Jan, do you prefer to place implant in regenerated bone or a short implant?
A short implant.
Jan, do you prefer to go back to machined surfaces, or do you keep the advantages of minimally rough surfaces?
I think that there is a hype of modifying surfaces right now. Implant industry has reached an endpoint of surface modification. So finish, thank you. And I believe that a machined surface, if placed in the old-fashioned way, with a longer type of submerged healing, is exactly as good as any other type of surfaces. But for a peri-implantitis point of view, I don't know. Because in the old time, you remember that Mariano described to you that success of implants was always reported in these mean values that didn't change over time. So it was 40 years or 50 years or 60 years as nothing happened. It's only when you start to look upon the individual implant that you see that there is a change. And I think surfaces right now are hype, and I think that the traditional machine surface may work just as well, but I don't know. It's a speculation.
Klaus, I reverse the questions also to you. When would you prefer an implant rather than a tooth?
When would I prefer an implant over a tooth?
Yes.
Never.
When would you prefer... When would you prefer to replace with an implant a compromised tooth?
That depends on the degree of compromised situation and whether or not it is feasible to be treated. I certainly would prefer to treat a tooth that has attachment loss or whatever, endodontic problems, before I would extract it.
So with regards to short implants or regenerated bone?
I don't think there is anything that the one is better than the other. The short is certainly simpler, and simpler normally is better.
Mm-hmm. And when it comes to the issue of the surfaces, do you agree with Jan? Do you want to add something more?
That's a tough one, because we come from two different camps. But I would say that the ideal implant surface has to be looked at from the osseointegration point, from the maintenance point, developing peri-implantitis, but also from the regenerative point of view. Once you have peri-implantitis, you treat it. There you may want to have the surface modified, but I completely agree that all these features and putting whatever on implant surfaces does not lead to anything. I think we have implant surfaces today that work for these three. Maybe in certain instances a machine surface implant would be preferred, and in other cases not. But I certainly have learned the lesson that when modified, then moderately rough at the most, and not the rough implants that we used to have.
Well, we are going to thank very much the architects, and as we said before, we for sure will look forward to having them again in Europerio8. Clearly, these 25 years of periodontology in Europe have meant a lot for the development of periodontal science, but also have meant a lot for the development of periodontology as a professional specialty and as a professional field of dentistry in Europe. In Europe, of course, we all come from different countries. Each country is very different. The modes of practice are different. The modes of education are different. But we needed something that put all of us in a coherent manner towards our periodontal science. And this was the EFP, the European Federation of Periodontology, that we created exactly 25 years in 2016, next year. And when we did that, of course, one of the key features that we wanted to address was periodontal education. And for that, we had a superb professor, a convener, the person that put us all together, and that was Uwe van der Velden.
European Federation of Periodontology played a major role in it, because was founded in 1981, but one of the objectives was that education should be promoted. And we wrote guidelines for education for undergraduate students in the early 90s, and we developed a system of postgraduate education. And that's increasing nowadays, and we have, I think, a very nice 3-year full-time postgraduate education. So I think that is the major task for the future, that we try to get postgraduate programs in all countries of Europe.
And of course, any kind of profession, health profession, needs a scientific background and needs a scientific journal. And we were very lucky that when the EFP was founded, we already had a great scientific journal. The Journal of Clinical Periodontology at that time was chaired by Professor Linde.
The journal was founded by a number of societies which today belong to the European Federation of Periodontology. And the first editor-in-chief was Professor Hans Müllermann from the University of Zurich. And then after a couple of years I took over, and the current editor is Dr. Tonetti, who is doing a fantastic job with the journal. Its citation rate has increased considerably, and I'm very proud that he is the successor of me as editor. The journal is important for periodontology, not only clinical periodontology, but for different aspects also of the more theoretical or basic aspects of our clinical specialty.
So you've been alluded, Mauricio. We are also very proud that you are the editor of the journal. What does it mean for you to be the editor of JCP?
Well, it means to me, it means a great joy. It is the possibility to be of service to my friends, to our world. I think that the role of a journal is not prestige only. It needs prestige because it gives credibility to the findings we build our practice on. But the key element of a journal is to be able to communicate, to reach to most people around the world. I am delighted because our journal, your journal, is actually a journal that is available basically in every institution around the world. Every day, 1,000 different dentists access the journal to go and find answers, to learn something. 500,000 articles, actually 600,000 articles every year are downloaded to study them. This is incredible, and it's really the basis upon which, we can go and we can be credible. We can show that there is science behind our treatment. So I am delighted to be able to serve all of you in this position.
Thank you, Mauricio. And again, one of the other assets of the European Federation of Periodontology has been the organization of consensus workshops. We started 20 years ago, 2004, and it was Professor Klaus Lang who started in Ittingen the organization of these workshops. And these workshops have been the knowledge reference in periodontology and implant dentistry for all around the world. Now we have the possibility to organize them yearly, and we have the possibility, with the support of the journal and Mauricio, of publishing the proceedings that we all enjoy. We live in a world that information is fully accessible, but we need also experts to distill this information, to process this information in order to make something really tangible, something that is applicable to the treatment of our patients. Mauricio, you have been in all the European workshops from the beginning. What has meant to you to participate in the workshop?
Well, first of all, I lost all my hair. But no, I tell you, I wish you could be there, because it's an experience. It's something that is fantastic. We are there, we are somehow like monks, closed in this little cloister, and as we are there, we discuss, we exchange. And when people walk into this workshop, they are asked to take out all their conflict of interests, all the noise, all the industry support, all the elements that make getting clear answers perhaps a little bit more difficult. So I think it is an exceptional experience, and again, I think it's very useful as a user of the workshop, because I'm also a practitioner. It is fantastic because I can go back to my practice, reorganize things, and I can also reference in the workshops the standard of care today.
And again, we are wrapping up, of course. The other asset of the European Federation of Periodontology has been the organization of Europerio congresses. The same, more or less, we back to 20 years ago when we organized the first Europerio Congress in Paris. That was 1,400 people. Here, we are about 10,000 people. A lot of things have happened, but the Europerio Congresses have been a fantastic success story. And of course, I would like to ask to the founder, the convener, the one that organized the first Europerio Congress and has been overlooking the organization of the rest of the Europerio Congresses, Jean-Louis Giovanoli.
Today it's a lot of emotion to talk about that, but I'm very proud since I feel a little bit being the grandfather of Europerio, and I'm delighted to see that today Europerio became the first scientific event in the field of dentistry in the world. The committee was composed of Pierre Baini as the scientific chairman and Edwin Winkle as the treasurer. And I tell you, it was a very difficult adventure. And this meeting has been, a big success. At this time, we had around 1,800 people participating in the meeting. So it has been a very big satisfaction for all of us.
And of course, we get to Europerio8. We get to the end of the Congress. I would like to thank Maurizio Tonetti for having helped me with this session.
It was nice to be your sidekick, Mariano.
And I would like to welcome the person who has worked most, the person who has lived for this Congress during the last 5 years. And this person, of course, is nobody but Francis Hughes, that has chaired this Congress.
Diego, are you in the room? Diego? Where is he? Sorry, I just wanted to credit Diego who put that together. There he is, he's giving a wave. Big credit to Diego for that wonderful. Ladies and gentlemen, I'm afraid I'm losing my voice, but that's the excitement of Europerio. Have you had a good time? Sorry, should we try that again? Ladies and gentlemen, have you had a good time? Excellent. I've had an absolute ball. That's amazing. It's been an absolutely extraordinary experience for me. And as Mariano said, you've made it a record-breaking meeting with our final figures are about 9,700 people. But actually, I don't want to dwell on the numbers because it's the vibe I want to dwell on. and everybody, sponsors, exhibitors, have fed this back to me as well. You are an extraordinary bunch of people. Your enthusiasm, your energy, the fact that you're all still here and it's a lovely sunny afternoon out in London is astonishing. And I don't know whether you could feel the electricity throughout the meeting, but I certainly could. So I'd really like to ask you all to give yourselves a very big round of applause. Thank you very much. This has been an extraordinary journey for me, and I've had the pleasure of working with all sorts of people, and I'm sure I've forgotten some of them. I'm not going to shout them all out because I've put a list up, a couple of lists actually. And I'd like firstly to go through some of these people. The core committee of Mariano Corkwood and Nikos have been, we've worked so closely together, it's been a joy. And the EP8 conference committee, as I say, I'm not going to read the names out. Extraordinary experience here, extraordinary wisdom. And then a fantastic local organising committee. Again, I'm not going to go through the names, but I will pick out Michaela and Julie, because we've had huge support from the British Society of Dental Hygiene and Therapy. So thanks to the BSDHT. Now, you might notice that all the people on this list have a day job. It's kind of amazing that all these people who have another job, a proper job that pays money, actually have been able to put in so much time for this. I also want to credit the enormous number of professionals that I've worked with doing this extraordinary thing. Okay, firstly, again, I can't go through all the names, but I'd like to just pull out, firstly, to the organising, professional conference organisers, Mondial, who I'm sure you'll agree have done an astounding job. These are all the people from Mondial. I've worked so closely with them, it's been a joy. Stefan runs the whole show, and Florian has been the kind of overall manager. Constantine, Barbara, Ellen and Daniela particularly, we've worked, our inboxes are full of each other's emails, so I'd really like you to put your hands together for Mondial. And of course also, how could you not give a special mention to Monica, who many of you will always interact with. From BSP, Ghislaine and Helen, Fluent PR have done our press handling, WebGiz have done the abstract handling, TFI is our local PCO, London and Partners who've supported us throughout, Nitida, who are the extraordinary PR group who've been doing the videos, doing the brilliant blog. I mean, it's been fantastic to have the blog, and Paul Davis is sitting over there, Peter and Diego we mentioned, the staff at Excel. And I also want to mention the on-site staff, who I don't know the names of, most of them. They've been great, they're lovely to work with, and particularly I want you to put your hands together in a second when I say to all the tech staff, the technical staff. I mean, it's like a branch of PC World out the back there, I promise you, it's extraordinary. But they're so professional, but not only professional, they've been an absolute delight to work with, so helpful, always smiling, and made the technical aspects of a huge meeting like this go so smoothly. So thanks, guys. It's been great to work with you. And then finally, obviously, our sponsors and exhibitors, we couldn't have done this meeting without them. And then I've got one other group of people I really want to thank. Here we go. And these are the students from these three universities, the three dental schools in London, all of our willing volunteers who I think have done a fantastic job. And I'm going to ask those who are here to come up on stage and take a bow. Now's your moment. Thanks, folks. You've been absolutely brilliant. No, wait, just wait. And now, ladies and gentlemen, I believe it's glasses time. Put your glasses on, folks. You didn't get your glasses. Oh, they left them down there. Typical students. So, okay, off you go now. Thanks, Brian. Lovely. Go. Oh, thanks. All right, you can go now. It's brilliant. Well done. Thank you, folks. I'm not quite sure what that is. So I'm handing over now. So thanks, guys. Thanks a lot.
Hello, everybody. Don't leave the room too fast. We have a big surprise for you. So, before the end of this grand finale of Europerio8, we are here, and time now has come to look into the future. Please, put on your glasses. I hope you had a great time so far at Europerio8, which was a very, very nice event. And I have to present myself. My name is Michelle Renners. I'm coming from Belgium, and I am the next president of Europerio Conference. And it's my pleasure, thank you. And it's my big pleasure to present you my fantastic team. So I will ask Søren Jepsen, my president chairman, who is coming from Germany. My treasurer is coming from Austria. You know, all of you know him. It's Gernot Wimmer. And we also have the participation of Bruno Loos, who is representing the academic world. And together with the Dutch Society of Periodontology, of course, and the entire EFP committee, we cordially invite you for the next Europerio9, which will take place in June, from 20 to 23rd, 2018, so you can write it down directly now in your agenda. And it will be in the fantastic and exciting city of Amsterdam. So I thought I had a surprise for you. I said this. Okay, so please, there is one of you, there is one lucky guy which is in this room. And if you look carefully to your glasses, have a look if you have a crown marked on your earpiece. You have the light, you can check. And if you do, then it's this beginning of a fairy tale, I would say, because you will have the registration, the travel and the hotel will be offered for coming to see in Europerio9 in Amsterdam. So please, the lucky one here can go to the EFP village and we will give him all the information about it. So now I may pass the word to Søren Jepsen, who is the current EFP president. And I wish you, in the name of the entire EFP, I wish you a nice day remaining in London, and have fun, enjoy your weekend, and I hope to see you again soon. Bye-bye.
Dear colleagues, please don't run away now. Give me 3 more minutes, okay? I take my Europerio9 hat off, and I'm EFP president again. And well, at this point, I really would like to see Francis Hughes, he's here. I'd like to see Mariano Sanz, Corco Demere, and Nikos Donos up here, because I think we all want to give them a big round of applause. Please, friends, come over here. I think it's unbelievable what Francis and his team have accomplished for arranging this record-breaking, fantastic, outstanding Congress. The best Europerio ever, the biggest one and the best one ever. So thanks again for your tremendous amount of work and your dedication, your enthusiasm. It's been awfully good. All right, now what we want to do now is that the five of us, we would like to thank you for being here with us and for coming to London and to make this such a big success story. So please. And we want to invite you to join us in our vision. Our vision is periodontal health for a better life. And on the occasion of 25 years of periodontology, as we heard, it's going to be next year, we will start a public campaign increasing the awareness for periodontology in Europe and hopefully all over the world. This is going to be addressed to health professionals, to policymakers, but also, of course, to the patients that quite often don't know what this disease means for their life, for their quality of life. So please support periodontal health for a better life. This is all what we are here for. And finally, please come to Amsterdam in 2018 for another Europerio, and we hope to see all of you again. Thanks for coming. Have a great day. Enjoy London and safe travels back. Thanks.